My name's Will Duffin, GP and Education Lead. If you're a paramedic, doctor, nurse, physio, indeed anyone working in healthcare who has a curious and adventurous mind, then this is a podcast for you. During this pandemic, we've all had to modify our normal way of working. We've had to adopt new technologies like video consulting, manage patients remotely, work in constrictive PPE, increased personal risk, dealing with poorly understood virus that always seems to be 2 steps ahead of us. Consequently, many of us are understandably fearful. But how do we transform this fear into courage that enables us to practice from a position of strength and deliver the best possible care to our patients? To explore this with me in this episode, I have the pleasure of welcoming Dr. Kathy Ryan. Kathy is the Medical Director of Brisdock Healthcare Services. That's the largest provider of primary care services, including out-of-hours GP within the wider Bristol area in the UK. Now, she's got a career-long fascination with managing clinical risk and the notion of courage versus fear-based medicine. Another unique thing I've noticed about Kathy is her interest in English literature that permeates through all of her communications, which are peppered with references from William Shakespeare to Mary Roach to Bill Bryson. Kathy's a proud Merseysider, and courageously, she took part in a Channel 4 TV series called Why Doctors Make Mistakes, in which she candidly reflected on a major clinical error that she made. Quick disclaimer, neither myself or Kathy are experts. We don't have the answers to this topic, but we hope to provide you with some thought-provoking dialogue. Kathy, welcome to the podcast.
Good morning, Will.
It's a huge pleasure to welcome you on. How's lockdown life treating you?
Well, gosh, Will, it is becoming strangely normal, which is itself strange, isn't it? I have rather reluctantly taken up running to try to keep fit enough. And I go running sometimes with my husband, who's a natural runner, and I'm an unnatural runner. So I go very much slowly, and he runs ahead and comes back to me. And a couple of weeks ago, we had this funny encounter with I think a homeless chap who was sitting drinking his can of beer, and as we came past, he said, "Are you two together?" In Merseyside, obviously, and my husband said yes, and he said, "And are you still in love?" And my husband, of course, said yes.
Lovely. That's always nice to the homeless community are interested in your marital relations and deeply caring for you and your husband. So, Kathy, when you're not out running, you are medical director of Brisdock. You're managing, leading a huge team of clinicians, which includes me, and we are trying to make difficult decisions and manage risk on a day-to-day basis. And you've got a huge experience accrued over your career of both being a practicing clinician and a leader. And this whole concept of fear-based and courage-based medicine, perhaps you could tell me where that came from and what does it mean?
Sure. So I coined the terms fear and courage-based medicine about 3 years ago, Will, in the wake of the Bauer case. The fallout from which I thought was just pretty grim. And I felt that the fear, reading the medical press and the general press and talking to people, fear was almost palpable. Well, and it perhaps also exacerbated something which I'd observed over many years, which is that our sort of collective appetite and capability of holding clinical risk was slowly but steadily going down. And we're meant to practice evidence-based medicine. I feel like I've been harangued to practice evidence-based medicine for maybe 25 years, and about which I'm a bit of a skeptic. And one of my many jobs in the past was as a research manager, national research manager, and in Scotland. And someone coined the phrase medicine-based evidence, which I really liked, and thought I'd like to see more of it then and now. Anyway, we're not perhaps mainly aiming for a critique of evidence-based medicine, but fear-based medicine is a bit of a riff on that. And I suppose my observation was that in reality, on the ground, fear-based medicine prevails far more than we understand, we acknowledge, and we try to address.
Kathy, what does fear-based medicine look like? What are clinicians fearful of?
Well, many things, Will, and I think it varies from clinician to clinician. And something I'd encourage colleagues who are listening to consider doing is something I've called a clinical risk analysis, where you sit down with your team and it's very not rocket science. You think about what drives your clinical decision making, and write it down, and you divide it into fear and courage axes. So we did this a year ago with Brisdoc, most of our senior clinicians. And it's just very interesting to see what comes up. So we wrote it all down. We then talked about it. And so one particular example that came up was a fear of being sued. And I don't know how much in your the world of extreme medicine, how much medico-legal the spectre haunts in the same way. I hope it.
Oh, hugely, and it's a big part of the courses that we teach. Is one of the first things that our delegates ask is, if I go on an expedition and things go wrong medically, will I get sued? That is one of the number one questions we get asked. So there's nowhere on earth as a practicing clinician where you can escape that.
Okay,
that
no
fear.
Immunity. So I, as a leader, I am not frightened of being sued. I have been sued twice from the time when I was a full-time GP. I think the average quota is that a full-time GP can expect to be sued twice in their career. So I've had mine, thank you. But I think so. My observation as a leader, Will, is that having overseen millions of clinical encounters by this point, is that medico-legal actions are rare. Really rare compared to the number of patients and cases we deal with. And so living that as a leader has put it into a perspective for me. And we talked about that last year when we did this exercise, and one of the lead GPs said that was helpful because he didn't realize it was pretty rare, and people, I think, see it as much more of it might happen any minute thing than is the reality. That's not diminishing the unpleasantness when it does happen. I didn't feel too chuffed when the letters landed on my mat, but still, it's understanding the fear and trying to get it into perspective. So coming back to the clinical risk analysis, I collated the fear and the courage comments into things related to the clinician, things relating to the patient, and things relating to the system and the team. So, and so, for example, guidelines came up in both. So I think, of course, guidelines can be helpful, but they can also be constraining and fear generating. If I depart from guidelines, am I going to get into trouble? So I think guidelines promote sort of what I call didacticism. Don't know if that's a word, and they don't promote wisdom.
I completely agree, Kathy. I mean, I think increasingly we're seeing guidelines treated more like tram lines. And I think perhaps part of that shift is driven by the medical legal process, whereby we're seeing clinicians on the front line are being judged not by their clinical wisdom, how they made a patient-centered decision in that specific scenario, but how their practice compares with the NICE guidelines or the guidelines in that area, and a very kind of generic template which perhaps wasn't appropriate in that setting. I think that's partly only fueled that fear that if we do depart from guidelines, we will be judged very harshly when it comes to coroner's inquest or a medical legal process.
Yes, and that said, it's not, of course, easy to write good guidelines.
Right.
But somehow, I think we could be cleverer about it.
Perhaps one way is enabling or promoting clinicians to use their own judgment and not just read a list of bullet points off a screen.
Yes. I mean, maybe that should be made more explicit. I think there is something in NICE guidance about individual decision making and what have you, and I think they do mean it, but they then, of course, do go on to tell you to do A, then B, then C, and if the if the patient's not having it, or you just think for whatever reason this isn't the right route to take, it can be difficult, and that comes back to, of course, good clinical communication and rapport with the patient, and real proper listening, which I think, much as probably most people listening to this are seasoned clinicians, I think we can always listen better.
Yeah, good old-fashioned stuff works the best. Yeah, that's not gone out of fashion, has it? Just listening to our patients and communicating carefully with them. So that's a really interesting exercise that you mentioned. That's something you did within your team, where you've got a tool. I can see you've got it written down there in front of you, and you went through individually and collectively as a team what your fears were. That's a really interesting exercise, and you found that fear of being sued was number one.
No, I probably wouldn't say it was number one, Will, okay. But it's one of the prominent fears.
Yes.
We didn't actually do a sort of hierarchy, and it was really just a laying out of the stall, if you like.
What were the other fears that were unveiled in that process?
So I think, in looking back at this today, Will, there's a mix of things which in this which either promote fear-based working, or the potential consequences of something not going well. So there's a sort of a mishmash. So some of the things relating to fear are, for the clinician, are you've had a recent complaint, or your best friend has just had a really difficult case, or you're worried about just, and I think this is probably common to all of us, getting it wrong and causing harm. And I I particularly owned I have a fear of getting it wrong as a medical director. So, which would just be, especially if it was something fairly major, would that just be bloody embarrassing, wouldn't it? So, when you're in a leadership role, you have a degree of exposure. When, in fact, one of my GP colleagues came to sit in with me on Sunday evening in an out of hours shift, or IUC as we now call it, and I think it was very helpful, because what she realized is I'm not a magician either. I just, go through the same stuff and have the same head scratching, and don't know everything. In fact, increasingly think I don't know much at all. And that's what we're all doing in medicine.
I think that's really great to hear that, Kathy, because especially some of our junior colleagues that will be listening might think that, as you get more experienced in your career as a clinician, that you get to this zenith where you don't have to make difficult decisions anymore, because it's all just clear. You've got enough accrued experience and knowledge where you can just kind of quick fire. You can know what's what, and you can relax. But you're saying you never really actually do get to that point.
Well, I think if anyone ever gets to that point, they need to immediately retire.
Yes.
So coming back, if I may, so some of the other fear things I think are patient related, are where the patient has a problem that just isn't easy. No one's managed to solve it. Or where there's a dissonance between what the patient wants and what the family wants. Or where there's a dissonance between what I think's in the interest of the patient and what the family thinks are the interest. So there's that sort of tension makes walking a courageous walk more difficult.
Yes, I really like that idea of dissonance between your agenda, the patient, the family's agenda, and what about some of the human factors that feed into our decision making? What about if, in out of hours, we're often working in unfamiliar bases, with a lot of professional isolation. We're stuck in a little room. We might be dying to use the loo. We might not have brought our lunch with us. We might be kind of desperate for caffeine. How do you think they feed into our ability to make courageous decisions?
Well, yeah, a good point, Will. I think those very small but important things have a really significant impact. And actually, in my list in front of me on the courage side of the page, there are things like well-fed and watered, familiar environment, things running well. So, just like the printer working. And these days we're doing video consultations, which even I have embraced as a cheerful technophobe. But the webcam has to work, and I think it's I was surprised in our discussion at how much those and maybe I shouldn't have been surprised how much those very little basic human needs need to be okay, so that then people can grapple competently with these clinical decisions and risk holding. And it did chime with the I don't know if you saw it, the GMC did a big thing on doctor wellbeing, which was published late last year, in which they identified, and this was part of their response to the Bauer-Garber fallout, which was good. And they talked about, I think, autonomy, belonging, and competence as being three key things that are planks of our well-being. And one of them, they came back to things like overnight staff having access to hot food. So I think, and perhaps particularly in your colleagues who will be in perhaps quite difficult physical environments. I think still probably paying attention to what can be done, what comfort can be brought to the person who's doing the doing and those around them. Because I think that promotes courage-based medicine more than we think.
So there's a huge role that the system has to play, and clinical leaders within that system in enabling courage-based practice in the clinicians. One thing I've observed, Kathy, is there's good evidence to show that doctors or other healthcare professionals who've been sued are much more likely to practice defensively in the wake of that very stressful, difficult process. You've been sued twice, and yet you are a huge advocate for not allowing that to cause you to retreat back and not be able to tolerate clinical risk and hold risk. Could you perhaps reflect for me on any particularly memorable patient encounter or episode that's really taught you something, that's really changed you in a profound way?
So yes, Will. Although just to go back to the being sued, which did have its effect on me, and the two cases landed within 2 months of each other. So one of the fears then is, God, I'm going to get another, however many, which thankfully, touch wood, I didn't. So having these emotions in as a response to being sued, and it is of course appropriate, and the fact it affects our practice is understandable. That the key thing is to be conscious of it and to try and talk about it and mitigate it. But coming back, so my probably seminal clinical encounter in the line of openness and what I now call courage-based medicine was with a patient in A&E, probably about 23 years ago, whom I'll call him Fred, on whom I missed a fracture. And I missed it because I didn't x-ray him. And I happened to be doing a dressing clinic when he was sent down from A&E, having been sent by his own GP with persistent pain. So I'd seen him about 6 weeks earlier, I think. And the nurse said to me, "Yeah, this guy's waiting, and he's, quote, hopping mad." And I said, "Oh, pull the CAS card," and I assumed it was one of the SHOs. And she pulled the card, and I can still see the moment now of us both looking at it and seeing my handwriting. And she immediately said, "I'll get someone else to see him," which itself said something. And I think I'm pleased to say I did not hesitate. That no, I will go and see him, which I did. And it was probably one of the most uncomfortable encounters of my career, because he was very angry. I just apologized, and I held up my hands and said I made a mistake. I was looking at it thinking, why did I not x-ray you? Do you ever have those cases where you look back and think, why did I do that? Or why did I not do that?
Yes, absolutely. Yeah, I definitely felt that.
Anyway, I apologized several times, and got my boss to see him and got a specialist appointment, and he was having none of it. And he stormed out saying he was going to sue me. And I was upset. I was a bit shaken. I was annoyed with myself. But what was done was done. And then about 3 weeks later, I was, I think, just finishing off something in resus. There wasn't a patient there, and someone came in and said, "Oh, this guy Fred is outside and he wants to see you." And I thought, oh, he wants to tell me about his legal actions progress, I expect. So I went out, and completely unexpectedly, he said that when he got home and calmed down, he thought that we do all make mistakes, which of course is very true. And he appreciated that I was honest, that I didn't make any excuses, and I just said sorry. And he even apologized to me for getting so angry. And I was just, blown away that, wow, that, you know, well, that's just good, isn't it? To the extent that I wrote it up and sent it to the BMJ. So they used to do these filler articles with little sort of vignettes, which I don't think they do anymore. To bring them back, I think. And they agreed to publish it, but they said they needed Fred's permission. So I wrote to Fred, and I was actually on maternity leave at the time. So I wrote to him from my home address and explained I was off and I just had a baby daughter. And he sent me back this letter, which I've still got, which he was very happy for it to be published. And he said, I hope your daughter grows up to be as clever as her mum and less angry than some of her mum's patients.
Oh, wow. How incredibly humbling that must have been.
It was just lovely. And, so yes, I still think very fondly of him. And indeed, I did a workshop in my last job about clinical risk. And on this letter, Will, was a phone number. So this is maybe 13 years after this happened. And on impulse, I phoned the number and he answered. And we had a bit of a chat. I think in truth, he hardly remembered me, but and had some other more serious health problems by then. But it was really lovely just to say a hello again.
So there's a moment of quite remarkable insight, both for you and for the patient, that happened after that encounter when you both had a chance to kind of reflect on that case. And there's something in there about a recognition of your shared humanity, and you almost kind of formed a strange bond through that process.
Yeah, we did. And probably it actually had much more of an impact on me than on him. And there's an element of luck in it, as in all these things. A different patient might have reacted differently and gone ahead with their court case, and so it's the world isn't a bed of roses, is it? But nonetheless, that's what happened, and I sent it to the BMJ. It triggered a few of those rapid responses and discussions, and then as a result of that, I was approached by Channel 4, who were putting together this series called Why Doctors Make Mistakes, and not too surprisingly, we're having to work quite hard to get people prepared to go on it. And this is like 20 years ago, so the term clinical governance had only just been coined. I'm not sure it's much easier now, but and I thought long and hard and took advice and all the rest of it about whether I should participate, because they didn't want to talk particularly about the fracture case. They wanted to talk about my my one major really stupid error, which was when I overdosed a patient with diamorph when I was an A&E SHO, so now over 30 years ago, and the patient had a respiratory arrest, thankfully survived, and which I did agree to go on it. I felt that they were trying to do an honest examination of why things went wrong and look at how complicated it can be, and how The way drugs are laid out in an anesthetic cupboard can be a key contributing factor to the wrong one being selected. So all of those small and large system things, which, from my understanding, fast forwarding to the Bauer Garber case, there were many system issues, and part of the sense of injustice was how she became the sort of the focus when there was a much bigger picture. So the program, there are clips available on YouTube if anyone's really bored.
We'll put a link to those in the show notes,
well,
Kathy.
I would not encourage that. Well, and it was, in retrospect, it was a bit over dramatic the way they did it with all this music and sirens and things, but that was probably of its time. And my error was actually really mainly my error, just a stupid moment of not thinking, rather than any bigger system thing. So it didn't get much sort of digging into in the program, but still, I look back and I think I was in my mid-30s, didn't know where my career would go. It was quite a courageous thing to do, to tell the nation.
Absolutely, yeah. To put that out to a general audience, that's incredibly courageous. I think the thing I'm most interested in is how you've not enabled that, not allowed that to taint your decision making. Let's move away from the concept of fear-based medicine. I feel like we've been able to define that. Let's move on to courage-based medicine and what that looks like, and how you've moved on from those complaints that you've had into a bolder, stronger landscape. Tell me about that.
Okay, so I think courage-based medicine is not about doing anything super heroic, Will. It is about, and I'm open to discussion on all of this, of course, but I think it's about understanding and owning and managing our fears. And not allowing them, or trying not to allow them, to distort our decision making. So fear isn't wrong, and fear and courage really are probably on a spectrum, and you can be too courageous and end up being reckless. But I think there's a fundamental message around physician know thyself. And I think we could benefit from much more talking about our fears and exploring them and trying to understand them. And I think, as well as having had a cup of tea in the last 2 hours and having a printer that works, and having so one of the things I in a privileged position of being a leader, I like to think, if someone in Brisdock gets something wrong, I will support them, and I have attended inquests with my GPs, and I've now it doesn't mean I dodge the sort of, if I think what they've written or an action they took was not ideal, I don't shrink from that discussion, but overall, you're an individual clinician and I will back you. And so I think there are many things which enable courage-based medicine, courage-based leadership, of course, being a key one, but coming down to the individual, understanding one's fears is, trying to mitigate them is a good starting point.
Yes, and some of the received wisdom on the nature of fear is that, or the nature of courage, in fact, is that it's not about not being afraid, not having fears. That is an inherent human trait. We're all fearful, but it's how you rationalize and process those fears in order to make courageous decisions. Got a great quote here from Winston Churchill: "Fear is a reaction, courage is a decision."
Yeah. Yes, absolutely. Yeah. In fact, my mum used to say, Will, that when I was born, I looked like Winston Churchill. So, yeah, I agree.
You're a Winston Churchill looking baby. That's great.
I like to think we were all babies, just do look like him. But yeah.
Yes, yes, and I really like, Kathy, you're talking about physician know thyself, the role of self awareness and um, being able to name your fears. And there's a whole practice called fear setting that many people do, which is something that I think the Stoics were quite initially coined, but I think that the process that you did with your team, and perhaps that's something that our listeners could do as individuals, is think, what are they afraid of when they go into their next shift? What could possibly go wrong, and maybe just write those things down. And do you think that would be a helpful way of unpacking those fears and perhaps being able to reorder them in our head and show to ourselves that perhaps many of those are unfounded, and actually, if any of those things did happen, we could probably actually deal with a lot of the fallout of any of those things.
Yeah, well, I
What do you
actually very
think?
much encourage listeners to do it before they go on to their next shift. It's a good thing to do with a glass of Rioja and a bit of time to actually look in the mirror and think, you know, what drives my clinical decision making. Uh, yes, so I think doing it as an individual is healthy. I think doing it with colleagues, with your team, is probably more fertile. But you do need to have a climate of trust to be able to, for me to just say out loud, I would be embarrassed as medical director to, you know, to screw up, is something I need to know my team's okay with that and won't go think, oh, bloody hell, Um, um, the other sort of workshop type thing I encourage people to do, which again is not rocket science, Will, is something I've called things that go bump in the night, which is, in fact, you could also do around the table, informally in a social setting, as long as it's confidential, where you just bring a case which kept you awake at night. And when I introduce the session, I talk about a case recent-ish which kept me awake at night, which was in the IUC service of a 5-day-old baby, where I was asked by a nurse to put my head into the room and have a quick look at this baby. And from past experience, head in the room consultations can be a bit of a tripwire. And the baby had a mucky umbilical cord and was fine, basically, but she told me some observations, and I basically made reassuring noises, went back to my work, and then I woke up really early the following morning and remembered the heart rate, I think, was 100 or 110. And I just had this, like, that's quite low for a very small baby. And like, I was awake in an instant. And I then got myself into this, in retrospect, stupid spiral of, oh my God, stupidly Googled umbilical cords and found this condition called exophthalmitis. Yeah,
Exophthalmos, or oh right,
yeah, where
exophthalmitis,
it all
right?
goes in, and
Yeah.
the baby gets septic, and the game's up, sort of thing. And my rational head at the time was saying, "Don't be stupid." And of course, in the end, the baby was fine. But so what I found was I talk that out, and because I've been there, I've walked that walk. It gives people, I think, permission to talk about their own, heart stopping, sick inducing moments, which we have all had. And it's just, I just think we should talk about this stuff more and look at.
Absolutely, and that's something I can really relate to. I think we've all had these moments where we've maybe in the evening over dinner we've just had this realization: oh, I just remembered I forgot to do this. I forgot to drop these bloods off the lab, or I didn't check this thing with this patient. Or wait a sec, that I remember seeing that clinical sign, and what did I do about that? And then suddenly you're phoning back in, and you're trying to get someone to check results for you and review the patient. And where does that end? And I think that could be very destructive for our own mental well-being. How would you suggest that people could perhaps compartmentalize their work and prevent having these after-work moments of panic?
Tricky, of course. I think if we were all eternally vigilant and kept perfect records and did it all right, then that wouldn't happen. But that just isn't what the world is like. I think if we have that middle of the night or middle of dinner or middle of shower, oh my God, I didn't even think of an ectopic or I think you have to work it out in the moment. You cannot. So when I've had those experiences, I can't just put it to one side. You have got to make the phone call, or you've got to in this baby case, actually, I found we didn't have a contact number on the system, or the contact number was for a parent's friend, who we couldn't get hold of. And I had to, as you will know, Will, we have quite a strict home visit policy, which is like my baby, that home visit policy. And I had to really resist the temptation to send out a visiting car to check that baby was okay. I did resist the temptation. We eventually got hold of Mum a couple of hours later. But, how can we... those moments are better avoided, of course. So trying to be conscious of things like, those head in the room consultations, things like the last consultation in any shift, the risk goes up. Mistakes are more common because we are starting to switch off. So, being aware of those landmines that we can all step on, maybe we do it a bit less.
Yeah, absolutely. I think one test that I run through in my own practice is if I'm in the middle of a challenging encounter, I ask myself, with this decision I've just made, I battle test it in my own head by asking, am I going to go away and worry about this? Am I going to lose sleep over this decision? And if so, perhaps it's not the right one. And I think that's a way of tapping into that intuition that we have and vocalizing that, and then acting on that. Because I think it's very often, like you say, that these things can be prevented at that time. We kind of know that it's not the right course of action, but we really have to just stop, pause, and reflect on that decision. And is it the right thing?
Yeah, we do, Will, although there's a balance in that, because any group of clinicians, there's a spectrum of comfort with risk holding, and some of the more risk averse clinicians would and could send everyone to hospital and do every investigation, and that would make them sleep at night. So, a part of the whole challenge is, what does good look like? In truth, we don't really know. But the ends of the spectrum are probably not good. And how can we, so part of my task as a leader, and particularly at the moment with COVID, is how can we encourage and support courageous practice amongst all of our clinicians, including the more sort of jittery ones.
Yeah, so that's really a huge challenge, because, as you said, everyone's somewhere along that spectrum. Some people are much more comfortable with holding risk than others. It's very much a personal attribute. But ultimately, I think the key point you made there as well was that as GPs, as senior clinicians within that organization, somebody has to shoulder risk. Someone has to take that and make a decision. And that's how we add value. If everyone was deferential, if everyone just passed that risk on and kept referring on, we'd never make progress.
Well, the system would sink by tonight. Yeah. And I think one of the absolute platinum value things of general practice, both in hours and out of hours, is that we are good at holding risk and allowing time to tell us the story as to what to do next. And I think that's a real art. Medicine is as much art as science, Will.
Now, one theme that emerged when you were describing courage-based medicine, Kathy, is this idea, this notion of confidence. And we need to have confidence in our own abilities, presumably, to be courageous. I mean, confidence gives us that power to act on our convictions, to have faith in what we're doing, and to take the appropriate action. However, the flip side to this is overconfidence. And whilst confidence feels good, I think overconfidence also feels quite good
in the moment.
You almost don't know that you're being overconfident, and that kind of enters the realm of being unsafe, being perhaps quite gung-ho or reckless with your decision making. How do we know, Kathy, when we're being appropriately confident in our own abilities and when we're bridging into overconfidence and recklessness with our decision making?
Yeah, good question, Will, and reminds me of an interview for a GP job which I attended many years ago and failed to get, in which I was asked, how can you avoid making the same mistake with ever increasing confidence? And I was flummoxed by the question, which isn't quite the same as what you're saying, but I think there is, I think we have to allow peer review, and whether that's a sort of formal system which we have within Brisdoc, as you know, or it's in general practice, people are looking at each other's notes all the time. I worked as a single-handed GP for about 2.5 years, picking up a failed practice, which was another thing about, courage and how things can go wrong. That's a whole other story, Will. But I realised by the end of the couple of years, much as I had enjoyed it, that it wasn't really a healthy environment because I was too autonomous. I didn't have I had other staff, of course, but I didn't have other GPs sort of looking over my shoulder, sitting alongside me. So there's something about that sort of sense checking over time. There's something about, again, self-awareness. I think the individuals who become overconfident, and there's been some, famous and, very sort of upsetting examples of people who've gone miles out with normal practice, and now subject and have been subject to criminal investigations. So there's something about individual humility and self-questioning and healthy challenge, I suppose, of one's own, am I okay at this, which can go the other way, and people can and this is quite a thing in medicine, people can be too self-critical and think they've got to get it right all the time, and it's a balance. Well, just about what my dad was my late dad was a wise old soul, and he used to say to me, in everything in life there's a balance, and I have slightly amended it, and my version of it is, in almost everything in life there's a balance.
Yin and yang, yin and yang. So that self-conscious, that's overconfidence. Now, there's another perhaps potential barrier to courageous practice, which I want to quickly unpack. And this is the idea of perfectionism that you just touched on. So this is where people develop traits of being very self-critical, very intolerant of mistakes, feeling that they've never quite done the job well enough. And I wonder whether within medicine as a whole, the educational system has bred that in many of us. It's a system that prizes ambition, achievement, control, high grades. There's this UCAS form mindset where we're encouraged to be high performers in all aspects of our life. There's no room for weakness, vulnerability, or failure in this model. And I think many clinicians find themselves trapped in this mindset, and they're naturally caring people. They want to do the best for their patients, and that desire and that drive can become quite crippling. What would you say to that?
Well, difficult, Will, and I'm quite a long way removed from the medical education system these days, and I recognise what you're saying, and I would hope that at medical school and in early days that that the importance of self-knowledge, of self-forgiveness, the term I came across recently, self-compassion, are just as important as getting it right and scoring well in the exams. And but I do know what you mean. There's something about, just to get into medical school, it is a competitive environment, which there's something sort of not compassionate about that, isn't there? But I think if there's an individual, and there may be individuals listening who think, recognizing themselves, if you like, then I would be wanting to ask, if that were one of my GPs, where that comes from, and try and unpick it and understand it. And some people have had that from childhood. They've had high achieving parents who've had high expectations, and all their kids have ever been sort of like told, both verbally and non-verbally, to do is hit the top note, if you like, and they spend their whole lives trying to do that. And
I think the difficulty really comes is where that high achieving mindset meets the system in which we have to operate, where we cannot physically deliver the best care that we want to deliver because of all the constraints, both on resources, on the way that we practice, the inherent uncertainty with dealing with undifferentiated illness, being that first point of contact as a GP. I think when you juxtapose those two together, that's a perfect recipe for fear-based practice potentially, and also discontent.
Yeah, absolutely. Well, I think it's sometimes a recipe for even more than that, Will, and the individuals, it just doesn't work out, because that marriage of managing uncertainty and holding cases and dropping the ball now and again, because we all do that, becomes not tolerable for some people. And they have to find other routes. But it starts. I had a reunion of my old school friends, Will, for our 50th birthdays, and I was struck at how little any of us had changed from when we were teenagers. And I was telling this to a friend who's a primary school teacher, and she said, "Oh, it's much earlier than that. I observe my 4-year-olds at school; they hardly change." So I think any of us who have kids, or who have influence with kids, that's where it starts. Get it right, or as right as we can, in terms of instilling balance and compassion and support and honesty. Even when they're driving you mad.
Kathy, do you think that appraisal and revalidation is a useful tool to promote reflection, self-awareness, self-compassion, or is it a meaningless administrative paper machine in which already competent doctors prove that they are already competent?
Good question, Will. I have not been sorry not to have an appraisal this year. and the truth is somewhere in the middle. It's a balance, Will, because we have to have some sort of regulation, but I think we could do it better. I think the appraisal system, as it's grown, has become a bit of a monster of stuff, and it's it's not. Come back to what I said about guidelines. It's not a promoter of wisdom. So it'd be nice perhaps to, I don't know, start appraisals with just a blank piece of paper. Or with clinical risk analysis, or something that's, this is about you as a person. It's not about the courses you've been on and the often slightly sterile learning points that you record. It's about you, the human being.
Yes, I feel it's kind of grown into this behemoth. It's just the amount of different things you've got to complete for your appraisal. It's got very prescriptive, much like clinical guidelines have just exploded and expanded. And I really like that idea of just starting with a blank piece of paper. Just stripping it down to essential conversation where you just get to have just think about your own practice, with a fellow clinician, without all of the noise and distraction of all the different box ticking that you have to do. I really aspire to that. I really buy into that, Kathy.
In fact, well, we could suggest this to whoever's listening, that the blank piece of paper has how can we promote courage-based medicine, and then how are you?
Yeah, discuss. Yeah, I love that. Brilliant. Well, Kathy, it's been a immense privilege to have you on the podcast. And I'm really glad you've taken the time to do this. I know you're a very busy person, but I think this notion of courage-based medicine is something we should all be trying to weave into our practice.
Well, Will, it's been a pleasure. Thank you for asking me, and I'm interested to hear what your colleagues think, and if they undertake clinical risk analyses, what they look like. And yes, I hope we can keep the conversation going.
Absolutely. And if people wanted to reach out and connect with you, what would be the best way for them to do that, Kathy?
I suppose via email. Will, do you want me to say my email address, or you put it on the end of it?
We'll pop that in the show notes. Yeah, so get in touch with Kathy via email if you've got anything you want to say. So thank you very much, Kathy. So that's courage-based medicine. So it's not about anything clever or anything super heroic. It's just about recognizing, owning, understanding our fears, and despite them, making the best decisions for our patients in any given scenario. So some really, really valuable wisdom from a colleague and senior leader within the NHS. Thank you so much, Kathy. And I'll leave you with a quote from Nelson Mandela. I learned that courage was not the absence of fear, but the triumph over it.